Good evening, everyone. Welcome to our 78th Blue Hills Virtual Seminar. Blue Hills Virtual Seminar is a platform that allows healthcare professionals to discuss current management updates of different health-related topics for better patient care. And this platform is brought to you by Blue Hills Ethiopia, a medical consultancy company founded by medical doctors and a computer engineer, and we aim to be an influential healthcare leader in creating a skilled community through easily accessible knowledge and preventive medicine. And I'm your host, Dr. Ihenot Adela, a general physician and first aid trainer from Blue Hills Ethiopia. Today, it's a pleasure to have Sara Paulos here with us to have a presentation on the introduction to healthcare quality. So for those of you who don't know Sara Paulos, she is a public health professional and expert at Addis Ababa City Administration Health Bureau in Healthcare Quality Unit and a performance monitoring team. She has over decades of experience in healthcare quality management in facility and regional level. So Sara, the stage is all yours. You can begin.
በሀገርኛ ልጀምር። እንዴት አመሻችሁ? እኔ ሳራ ጳውሎስ እባላለሁ። as introduce me Dr. Hino, public health professionals and healthcare quality expert. I'm working the past 11 years in healthcare quality department director, and currently I'm working in Addis Ababa City Administration Health Bureau as a quality expert, mentor and coach. Today we are discussing together because it's adult teaching. I try to introduce the introductory part of healthcare quality. I think we will have better time to discuss, to interact, to entertain, to raise questions and a better discussion toward this introductory part of healthcare quality. So I start my presentation. It is expected and enabling objective after these sessions. The participant expected to define quality in the healthcare, and not only in the healthcare, in Ethiopian context. What do you mean by quality? Healthcare quality in terms of Ethiopian context, we have to define healthcare quality. And the second one is describe the Ethiopian health system and its quality context and challenges. And the third one discuss the quality management components and drivers of quality improvement. As you know, healthcare quality, it's around 8 chapters. This is the primary one in the introductory part. As the platform enables, we continue the next topics as a given time. And for today, we start by defining healthcare quality in Ethiopian context and about health system. Interchangeably, what do you mean by health system and what do you mean by healthcare quality? My outline focus on introduction and health system and definition of quality in the healthcare and the concept of quality management, including the dimensions of healthcare quality. And the last one is driver of improvement in the healthcare. When we try to define health system is an interaction between the healthcare provider, the service delivery facility, and the activity. The integration and the interaction of those three components make the system suitable for the delivery of quality of healthcare service. As we see the definition, this definition is accepted and launched by the World Health Organization, WHO, A health system is, as I said before, defined as an organization of people, institution, and resource that deliver healthcare service to meet the health needs of the target population. We have the target population, they need health. We have the people, the healthcare provider, not only the healthcare, the people who works in the facility, institution, and the resource. The resource, human resource, and supplies, and drugs, and all other resource. The interaction of this organized to make the health system suitable, affordable, and accessible for the target population. This is the definition of health system. Ethiopian health system. As I said before, we have to define health system in Ethiopian context. Before the definition, we have mission and we have also vision, which is launched by Federal Ministry of Health. Our mission, promoting the health and well-being of the society through providing and regulating a comprehensive package of health service of the highest possible quality in an equitable manner. So we have to promote health and a well-being of society through providing, regulating, and comprehensive package of health service of the highest possible quality and an equitable manner. Equitable manner means equitable. We will see on the dimensions of quality. We will define and see the others, the 6 components of healthcare dimensions, which is launched by the Institution of Medicine later on. And we see the vision. Our vision is to see the healthy, productive, and prosperous society in our country, Ethiopia. Ethiopian health system, its own structured. Current Ethiopian health system, which works in 3-level tier system. The primary health system, the secondary health system, and the tertiary health system. We will see. Ethiopian health tier system. As I told you before, the primary one is primary hospital, health centers, and health posts are included in primary level of healthcare, and all the general hospitals which are found in Addis Ababa and around the regions incorporate with the secondary level healthcare, and the specialty hospitals in tertiary level of healthcare. This is Ethiopian health tier system. Quality in Ethiopian health system. How will we see? How will we define? How will we find this Ethiopian health system in terms of quality? The first one is HSTP1, which is defined Health Service Transformation Plan 1, which lasted for the past 5 years, and replaced by Health Service Transformation Plan 2. Primarily, the Health Service Transformation Plan 1 dimensions. Those are the dimensions of Health Service Transformation Plan 1. The first one is quality and equity. Quality and equity. Quality means doing the things in a right way, in a proper manner, and equity is fairness. We have to deliver our healthcare service regardless of ethnicity, regardless of language, regardless of any other component, culture, norm, value, we have to address all the service quality fairly. Fairness of the healthcare quality. In the health service transformation plan, the primary agenda was quality and equity. The second one is Wereda transformation. Transform our Wereda, currently replaced by the subsidy, the 11th subsidy, transformation of Wereda, starting from the infrastructure, the organizational structure, we have to transfer the transformation of Wereda. This was the health service transformation plan, second agenda. The third one is compassionate, respectful, and caring healthcare provider. Compassionate, respectful, and caring for whom? For the client who come to our facility, we need the service. Our clients came to our facility with different types of pain. So we have to respect, we have to give care, we have to be compassionate. Because our health sector organization differs from others organization, governmental organization, because our clients are sensitive. They came with full of pain, full of hopelessness, full of so many barriers. So we have to respect them and give proper care with compassionate manner. This was health service transformation plan, the third agenda. And finally, information revolution. As you know, currently, electronic medical records and others, information revolution, HIT, which is day-to-day practice and actionable in our facility. But primarily, when we launch the health service transformation plan, almost all hospitals are not knowing about AMR system. So when we come to, after 5 years, launching of health service transformation plan 2, the agendas were these 1, 2, 3, 4, 5. The first, quality and equity, comes HSTP1 and also HSTP2, because quality is not static. Quality is a continuous process. Quality improvement is a continuous process which lasts from improvement to improvement, still to achieve our goal. That's why we are here, HSTP2, እንደገና ኢንክሉድድ ሆኖ የመጣበት ሪዝን ኳሊቲ ኤንድ ኢኩዊቲ አሹራንሱ ሳቲስፋክተሪ ስላልነበረ ስቲል ሄልት ሰርቪስ ትራንስፎርሜሽን ፕላን የመጀመሪያው ፕራይመሪ አጀንዳ ሆኖ መጥቷል። The second one is motivated, competent and compassionate. Compassionate, respectful and caring healthcare provider, which was HSTP1, changed to compassionate to competent, motivated, sorry. Compassionate to motivated, competent and compassionate. Primarily compassionate, respectful and caring, and HSTP2, when you come to HSTP2, motivated, competent and compassionate. The third one is information revolution, and the others, the new agenda, leadership and healthcare financing. The main reason, including the leadership and healthcare financing in the health service transformation plan 2, without leadership involvement, without leadership ownership, without leadership engagement, we can't proceed when we can't improve the service delivery of our care. It needs critical leadership involvement and also healthcare financing. The third one is health service development implementation plan. This agenda focuses on universal health coverage progress, accelerating progress towards universal health coverage. The second one is protecting people from health emergencies. The third one is transforming Waradas. And the fourth one is improving health system responsiveness. Responsiveness means making health provider responsive towards their clients who needs the clinical service and who came to our facility. We have to be responsive. When you come to national quality strategy, NQS, it has its own priority agenda. Nationally, launched ሲደረግ national quality strategy in 2008 and lasts still 2012. Those are the priority agenda. Maternal and child health. The second one is nutrition. The third one is communicable disease. The fourth one is chronic disease. And the fifth one is clinical and surgical service. Maybe participant, you ask why all this priority agenda? Because this is data-driven, evidence-based. የሆነ መረጃ ስላለ ማተርናል ዲዝን ኮንትሮል ከማድረግ ቻይልድ ሄልዝን ኢምፕሩቭ ከማድረግ ኒውትሪሽናል ስታተስን communicable disease and chronic disease and come across with clinical and surgical service. Those are the priority agendas, national quality strategy. And still, currently, those are our priority agendas. When it comes to achievement, as I told you, the previous slide, HSTP1, HSTP2, and HSIDP. After those actionable priority agenda, we can achieve quality management structure. Everyone, when you see our facilities, hospitals, and health centers, even, they have their own quality management structures. As a director level, as a team level, and as a focal level. We can achieve this quality management structure in our facility. The second one is capacity building in quality improvement. We can capacitate the healthcare provider on basic quality improvement concepts. That's why we can see some improvement, visible improvement, significant change in healthcare delivery. So healthcare quality capacity building activity is our achievement, including the seniors, even the seniors. Learning system. You can take this webinar as a learning system. Learning system means experience sharing, skill sharing, and knowledge sharing with different platforms like a webinar, on-site training, experience sharing. This learning system achieve ማድረግ ችለናል. The fourth one is dedicated resource for quality management system. Quality management is the most forgettable and ምንም መደብ የሌለው department ነበር. And currently we see the improvement, we see the change, we see the outcome. So dedicated resource for quality management system is implemented. Those are our achievements. When you come to National Healthcare Quality and Safety Strategy, which is launched in 2013 and lasted still 2017. Those are the goals, the targets. We can say improve health outcomes and confidence in a system. which means the first one is improved evidence-based care. Evidence-based care. Evidence-based care means providing holistic, quality and safety healthcare delivery. The provision of quality and safety healthcare delivery for our clients. The second one is improved people-centeredness. People-centeredness means our clients have a right to decide on their health. They should be part of the healthcare delivery and the decision. We can't say, I know about you. I know for you. We can't say. Our clients should be a part of our decision. They can decide on their health, regardless of a specific issue. Regardless of specific issue, we will discuss on the next topics. The third one is reduce preventable harm arising from care delivery. In other words, which means ensuring client safety, preventable harm arising from care delivery. When we give care for our client, we have to be cautious. We have to be protect them from unnecessary preventable harm, which means we deliver our care cautiously based on standard and properly. So we can ensure safety of our client. The fourth one is improve the efficiency of healthcare delivery. As we know, we do have limited resource, but we face a lot of problems. So we have to use our resource efficiently for those who need. So the fourth agenda was improve the efficiency of healthcare delivery. We have to improve utilization of our limited resource in the healthcare delivery because resources are limited. Create a culture of quality through continuous learning and improvement. Currently, quality activities, day-to-day and routine activity among almost all healthcare providers, almost all facility, because we can create culture of quality. Every healthcare provider deliver his day-to-day activity based on his job description, including quality of care, based on standards, guidelines, SOPs. So we can create culture of quality through continuous learning and improvement. Definition of quality in the healthcare, it differs from client, managers, and healthcare providers. Healthcare providers define quality in their own context. Clients define healthcare quality in their own context, and the managers, the facility leaders, define quality based on their own culture. We will see different definitions of quality in the healthcare among different stakeholders. The first one is Aves Donavedian, who create the Donavedian framework, who measures the structures, the process, and the outcome. Donavedian's framework is a system of ensuring quality improvement by measuring the process, the outcome, and the structure. In the facility, the three items are there. The structures means the building, the process means the way of the delivery of the care, and the outcome is our goal. So we can ensure our service is improved from the previous one by measuring the structure, by measuring the outcome, and by measuring the process towards the given standard. These Averts Donavedians launched this measurement of quality, and this topic is briefly and discussed by the next 5th or 6th chapter. This is what he says. Averts Donavedian define quality in this context. The kind of care which is expected to maximize an inclusive measure of patient welfare after one has taken account for the balance of expected gains and losses that attend the process of care in all its parts. He defined quality in the healthcare as it is. Quality definition in the Healthcare International Organization of Medicine, IOM, and now MAM. When you see the definition of IOM, healthcare quality, institution of medicine, quality of care is the degree health service for individuals and populations increase the likelihood of desired health outcomes and consistent with current professional knowledge. IOM define healthcare quality in this manner. We can proceed. So, quality stakeholders' perspective. Different stakeholders have different perspective towards quality. Even if we healthcare providers, before we know the perfect definition of quality, we do have a different perspective towards quality. By the way, quality is not only for clinical purpose. It works for personal purpose, it works for factory, it works for other organizations, not only the healthcare facility. This is another concept we will discuss in some other time. Different stakeholders have different perspective. Health managers, facility managers see the health care quality in this perspective. They want to see their facility image or the health system of their facility. As we discussed before, health system is the interaction between the healthcare provider, the infrastructure, the peoples towards the same goal. That makes the health system smooth and actionable for the service delivery. So healthcare managers, they see quality. I have to make the health system in my facility favorable or conducive for the client. They want to change their facilities image. If they are doing that, they said healthcare quality, facility ላይ I can implement ማድረግ እችላለሁ ብለው ያስባሉ። Then availability of human resource. Actually, this is vital. Without human resource, we can't do not only quality, demand of health service coverage, we can't address. Then the human resource, as we see the health tier system in Ethiopia, primary, tertiary, and secondary, the health professionals for specialty, for primary, and for secondary, it's different. Based on that, the human resource should be fully available in the facility. The third one is efficient use of resource, because they are the managers. If there is shortage of resource, they can't do anything. We can't do anything in the facility. That's why resources are limited, problems are unlimited ብለናል እንደ ሄልት ኬር ፋሲሊቲ ላይ። ስለዚህ ሄልት ኬር ፋሲሊቲያችን ላይ ያሉትን ሪሶርሶች ኤፊሽንትሊ መጠቀም አለብን። So the third one is efficient use of resource can ensure the implementation of healthcare quality in the facility ብለው ያስባሉ health managers. The fourth one is performance in key health indicators. Key health indicators, it differs among general, regional, and specialty hospitals. Key performance indicators that indicates the assurance of healthcare quality in our facility, because as Avets Donavidian says, we can ensure the service quality improvement by measuring the structure, the process, and the outcome. These measurable indicators, data-driven. That's why the performance in key health indicators ensures the improvement of the health service quality, as the health managers says. Other stakeholders, we, the healthcare providers. The healthcare providers see our perspectives of quality in availability of inputs. We know the shortage of medical equipment and supplies in almost all facilities. So if we ensure the availability of inputs, the medical equipment, the supplies, the human resource, and others, we can ensure the healthcare quality. The second one is an enabling environment, or conducive and pleasant. As we know, our facilities, are they enabling? Are they conducive? Are they pleasant? Everybody can answer, because everyone, by one or another reason, you can have a chance to see our facilities, how far they are conducive and pleasant for the healthcare providers. That's why all seniors, all healthcare providers run out from the government and go to the private end out of the country. So healthcare providers ensuring a healthcare quality by enabling environment. It should be conducive. So if our work area is conducive and pleasant, we can do our work, we can do our duty properly. The third one is staff motivation. In terms of staff motivation, it reveals in so many kinds, in terms of recognition, in terms of award, in terms of thank you. Somebody doing something special, if we say thank you for doing this, you can improve this, so thank you. Simple certificate, incentive, recognition. Healthcare providers need this, because the work area by itself is stressful. The profession itself is stressful, because our clients came with full of stress, full of pain, and full of so many things. That's why staff should be motivated, healthcare providers. That's why they say motivate. Staff motivation is one pillar of quality. There's decreasing mortality and morbidity. they are doing and they are trying to overcome the better outcome of the client. But if there is a shortage of medicine, if there is equipment, if there is a shortage of supplies, any other, and if increase morbidity and mortality, healthcare providers, they will not happy. And they measure the insurance or assurance of quality in terms of decreasing morbidity and mortality. All the clients came to our clinic or our facility, they have to improve from their pain or from their burden and from their disease. And healthcare providers define quality in the context of those components. Clients. When we come to client expectations, what did the client expect from us when they came to our facility? Staff attentive listening. Staff attentive listening. When they try to tell their, I feel pain on this, I feel pain on this, I feel pain for the past 6 months, I feel this, I feel this. You have to listen attentively with nodding. With nodding. I'm with you, I'm listening. That is sign of language, sign of language. They need this. And friendliness. Friendliness. Then we have to keep privacy, patient privacy. As we know, most of our hospitals are teaching hospitals, and the student nurses, the student resident, the student interns came to see the patient. So actually they have to learn because they have to learn. They have to learn again. We have to keep our patient privacy. And then they need their confidentiality. They need their confidentiality. We have to keep their secret confidential. We have to keep their feeling confidential. Waiting time. We healthcare providers, the bad thing, we have so many good qualities, but we can't understand sometimes. The patient, he came to our clinic to need service delivery. We have to improve and come back to his work. So timeliness of care, it matters. Unnecessary waiting time should be avoided. Properly, timely, adequate. You have to have the treatment and come back to, and after improvement, he come back to his work. He needs waiting time. Waiting time. If he came to the clinic and go quickly, he will be happy. When you measure client satisfaction, I'm happy. The 6th one is professional technical competency. Patient needs our competency. Healthcare provider should be competent to the position he assigned or she assigned. Technical competency. Update ourselves always. There are so many platforms to update our knowledge, skill, experience sharing. So we need to have competent. We need to be competent. We need to have updates. And the client needs technical competency of healthcare provider. Clean environment, availability of drugs. After treating the patient, go ahead and buy this medicine from the outside. He will not be happy. as much as we can, we have to avail all the drugs in our facility. That's why the CBHI launched, and its outcomes is significant. Community-based health insurance is significant roles in the availability of drugs, because we keep on the pharmacist the drugs for the CBHI customers, community-based health insurance registered customers ተለይቶ በፋርማሲ ውስጥ ይቀመጣል ይወስዳል ማለት ነው። ጉድ ክሊኒካል አውትካምስ ታክሞ መዳን ይፈልጋል ታካሚ። ኢንፎርሜሽን about his disease, about the disease prognosis, about the drugs, how he take the drugs, the care he has to take at home. All this information properly needs from the healthcare providers. Then finally obtain feedbacks. Client perspective, quality. Other stakeholders are clients, and they are vital for the facility, the healthcare sector. They define quality, as I mentioned. Other stakeholders, the broad community. What our community expect from the health sector? Accessibility of care. Easily accessibility of healthcare delivery, nearby facility, health center, health post, ambulance, this access to care. Community expectations, affordability. We are Ethiopia, low and middle income countries. So affordability is crucial. I mean, as I mentioned before, CBHIs, the one intervention to come across this affordability, because the drugs are too expensive, diagnostic services are too expensive. So community expect from the sector, the health sector, affordability of the service. Societal norms. We have to keep the society norms. Culture, ethnicity, religion. We have to keep the society norms. Community expect from her sector those activities. Finally, healthcare quality dimensions. We will have detailed discussion on this, but healthcare quality dimensions currently, if we properly implement in our facility the quality dimension, we can ensure our service delivery we deliver for the community, for the client, is quality. If we keep those dimensions, if we can't keep, so many consequences, so many problems are faced within the health sector. We will see each one. The first one is safety. Patient safety is crucial. Patient safety. Patient safety. What do you mean by patient safety? Patient safety? What do you mean by patient safety? Patient safety means absence of preventable harm. As previously said and discussed, prevent our clients from preventable harm, which means we have to keep the client safety. This is the primary dimensions of healthcare quality. The second one is effective. Effectiveness means goal-oriented. Care is given as per current knowledge and recommendation. The third one is efficiency. Efficiency is directly related with proper handling of or proper use of resource. Efficiently utilize our resource. Reduction of waste. The fourth one is equity. Equity means literally fairness, regardless of ethnicity, regardless of educational status, regardless of appearance, regardless of language. Equity is the fourth dimensions of quality. Delivered uniformly without discrimination based on geographically, gender, disability, ethnicity, and language. Timeliness of care. Reducing waits and sometimes harmful delays for both those who receive and those who give care. Timeliness not only for the patient, it's also for us, for the healthcare providers. If we deliver care timely, we can go timely. So timeliness of care, not only for client, but also for the provider. People-centeredness. As I said before, client is part of the service delivery we give for client. Decision makers, part of decision makers. Care, respect and respond to individual, family and community preferred needs and values. Integration. As we said, primary hospital, general hospitals, specialty hospitals. The service we deliver is different based on our status. So we give the service, we deliver the service integrated. Comprehensive care is provided in a coordinated way across the continuum of care. Comprehensively, we deliver the care who needs or who demand the service. Those are healthcare quality dimensions. In our facility, we have to measure our service both based on these dimensions of quality. The next topic is, what are the core elements or components of quality management in the healthcare? Quality management is broad concept. Quality management, they have three components, intertwined. The single component is not actionable without the two. That's why intertwined. This is Durand trilogy. As we see, the Berchuma. I don't know in English. Without quality planning, no quality control. Without quality control, there is no quality improvement. What we do in quality planning, in quality control, in quality improvement, we will see in the next slide. But keep in your mind, quality planning without quality control is not functional. Quality improvement without quality planning will not be functional. What's quality planning? Quality planning means a systematic process that brings system thinking to the highest level of leadership and governance. It lays a firm ground for the others two elements. What are those two elements? After planning comes quality control and quality improvement. A systematic process that brings systems thinking to the highest level of leadership and governance. It lays a firm ground for the other two, quality control and quality improvement. After planning, control, then improvement. What are the components of planning? I'm sorry. First of all, as I said, frequently we do have so many problems in the health sectors. So, when we plan to come across to achieve these problems or the gaps, we have to set priority. Which service is prioritized and addressed primarily? Setting priorities. How we set priorities, how we prioritize the problems based on their significance, based on their impact, and based on feasibility, and based on our resource. Can we address this problem by now? Do we have enough resource to tackle this problem? So setting priorities primarily. The second one is strengthen quality management structure. This is crucial. As I said before, after HSTP1 and HSTP2, our success, we can construct the quality structures among the facility at the director level and the team level and the focal level. So, strengthen quality management structure. We have to focus the quality management structures. The third one is data system. Proper data system should be in place. Properly document, properly registered, properly analysis, properly interpret. The fourth one is building capacity. As we discussed before, we do have so many platforms to sharing experience, to capacitate every healthcare provider, sharing experience like this webinar, training, on-site training, peer group discussion. We have to capacitate the healthcare provider. So building capacity is the fourth one. And finally, after planning, we start to doing quality improvement activities. So to doing this quality improvement activity, we need to have policies, we need to have strategies, and we need to have protocols and guidelines and SOPs. Because each and every activity in the healthcare facility governed by its own policy and strategy and protocols and guidelines. So, quality planning, then quality control. After planning, we start the activity, doing the activity for a quarter, for a month, and for 6 months. After that, we have to control the activity we do in the facility. How we can control? The first one is regulatory process done by expertise. External expertise means the regional level, the zonal level, and the ministry level. They came up with a standard and they measure our performance toward this standard. For the purpose of accreditation, for the purpose of green, yellow, and red certificate, the regulatory body came with a standard and control our service delivery toward the standard. The second one is measuring actual quality performance. What we are doing currently. Where are we now? Where are we? We have to measure actual quality performance. Compare it with quality goals. Plan versus performance. We plan, for example, we decrease surgical site infection from the current this percent to this. From the current 50% to 20%. The goal is 20%. The current situation is 50%. So at the end of the day, compare our success with goals. Well, compare our performance with our target or goals. Finally, when we compare our plan with our goals, there is a gap. There is a gap. Rather, we achieve 100%, there must be a gap. We score 90%, we score 50%. So the other 50% gap should be act on the difference. The difference means the plan versus the performance. This is controlling activity. Improvement. What do you mean by quality improvement? Quality improvement means it's a continuous process which is done by the frontline staff or the department itself or the facility itself by measuring its day-to-day activity, by monitoring its day-to-day activity towards the goal who targeted or who picked. As I said, quality improvement is continuous, whereas quality control is, as I said, primarily done by regulatory process and external body, periodically, quarterly, every 6 months, annually. They came with their standard and measure the facility performance. But when it comes to improvement, it's a continuous process. I'm sorry. It's a continuous process which is done by frontline staff. Means if we start to doing quality improvement project in surgical ward to decrease surgical site infection, the ownership will be the department, because the problem arises from the department itself. So the department staff is responsible for the improvement activity, which is continuous. Each and every activity daily documented and daily measured and daily documented. So quality improvement differs from quality control. It's a continuous process and which is done by the frontline staff. The responsible body is the department by measuring the performance towards the expected goal, which means the organized creation of beneficial change and attainment of unprecedented level, unexpected የሆነ ወይም ደግሞ ደርሰንበት የማናውቀው ፐርፎርማንስ ሌቨል ላይ መድረስ ማለት ነው። እና ያለ መድረስ ዴይ ቱ ዴይ አክቲቪቲያችን ሜዠር መደረግ አለበት፣ ዶክመንት መደረግ አለበት። በማን አክቲቪቲ የሚሰራው? በፍሮንትላይን ስታፍ። The department itself take the ownership and the responsibility of improving the service delivery. As a summary, compare and contrast quality assurance and quality control. When we say quality assurance, as I said before, expertise and best practice Quality control, concept from expertise, best practice, ideas from frontline staff. Type of measurement for quality assurance is input and process. When you come to quality control, process and outcome. Process of measurement in quality assurance, periodically, usually by external body. Quality control improvement, continuous, is internal by frontline staff. Ownership of the quality assurance is leadership and management. Ownership of quality improvement is, or quality control, frontline staff. Sustainability, when we see sustainability, quality assurance is external check for accreditation. As I said, periodically. Quality control or improvement in department is self-regulation through high level of continuous measurement. Finally, future state is for quality assurance is static and quality control or improvement is evolving. Finally, after we see quality planning, quality control, and quality improvement, total quality management comes. And in the first, as you see in the picture, quality planning is design what we do. The 5 components should be properly written here, design, when we design. Who will be involved on this project? What are we trying to accomplish? When we do the activity, where we do the activity, and how we do the activity. What, where, when, how, and who. Properly planning activity በደንብ ዲዛይን መደረግ አለበት። Because if we fail to plan, we plan to fail. I said it again. If we fail to plan, which means if we are not properly planned, we have to ready to fail. Because proper planning is mandatory. Then in the second, in the middle of the picture, quality control. The upper one is sporadic spike and the lower one is chronic loss. In between, you see the outlier, yeah, sporadic spike. When you come across to tackle the problem, unknowingly, outlier ሊመጣ ይችላል። አክቲቪቲዎቻችንን ሜዥር እያደረግን ሌሰን ለርንት እንወስዳለን። ኢምፕሩቭመንት አክቲቪቲ ላይ when we come to quality improvement activity, you can see the 3 circle. Inside the 3 circle, PDSA, which means plan, do, study, and act. PDSA cycle, it have its own session. We will discuss detail. For the time being, after quality improvement, the new zone of quality control. Sustain our improvement. About the data point, about the PDSA cycle, about the testing, about the sustainability, about the sign of improvement, we will discuss it on the next session. When we see this quality improvement principles, when we try to improve our service quality, these are the principles. Primarily, if we think to improve our service in the facility, we need to have why need to improve. ለምንድን ነው improve ማድረግ የፈለኩት? Because we try to face those problems in our facility. So we need to have knowing Why need to improve? Second, a way to get feedback. If there is an improvement or not. The third one is developing change for the specific problem. We have the problem. We want to improve that problem or the gap. So we need to have developing change. Developing change. How will we change idea? Link with improvement is another topic. Not all changes link to improvement. Before implementation, we need to have to test every single change idea. Finally, testing. What we test? The change idea. We have to test the change idea. If we start to see the sign of improvement, we go through. If we don't, drop it and another change idea. Testing. Finally, if the change idea potentially effective, we go to implementation after testing. Without testing, ወደ implementation መሄድ የለብንም because we lose our resource. If our change idea is not potentially effective before testing ወደ implementation የምንሄድ ከሆነ we lose our resource. And in addition, we can't achieve our target. Finally, the drivers. Healthcare quality improvement drivers in the healthcare. ምን ይመስላል? Finally, building with executive spirit, change and methods. If we have will to change the current state, for better, the idea comes. The ideas comes. If we have feeling to change the current state, the idea comes. What shall I do? What shall I do to change this from this, to improve this? If we start to think, if you have will, the ideas come to our mind. We start to say, aha. So if the ideas come to our mind, having the capacity to apply quality improvement theories, tools, techniques, and that enables the execution of the idea. First of all, we need to have willing to change the current situation. I have to change this. I have to change this. What will be the next step? What can I do to change this, to improve this? Which means the idea. Then if the idea comes after testing, we can use the quality improvement theories. Different theories are there for improvement tools and techniques. We can come across with the enabling idea. Health system, we try to define health system, which means the interaction of the people, the system, and the infrastructure towards the best service delivery. And quality definitions in terms of different stakeholders, clients, healthcare managers, healthcare providers, and community define healthcare quality in different ways. Cost of low quality care. If we lose the quality dimensions, we start to face so many problems. followed by low quality of care. We paid a lot, cost of low quality care. Quality management, it's a three component: quality planning, quality control, and quality improvement. And we try to see principles of improvement and drivers of improvement. For the time being, as an introductory, I'm done. And thank you for active listening. በጣም አመሰግናለሁ ያለኝን ሼር ለማድረግ እድል ስለሰጣችሁኝ ብሉሄልዝ ኢትዮጵያን በጣም አመሰግናለሁ። I want to say thank you very much the participant and the facilitators. Thank you very much.
Thank you very much. So I believe we took enough amount of time on the presentation, so we will be passing the question and answer section for today. So on behalf of BlueHills Ethiopia and all our participants, thank you very much for the very nice and clear presentation, and we hope to see you in the future with related topics as well. So Sara, if you have any last remarks that you want to address, please let me give you the stage one more time.
Okay, thank you very much. And one message. Quality is not fancy. Quality is not. Quality is demand. Quality is demand. Society demand. Doing quality means doing the delivery of the service which we have at hand. Make it standard. So quality is everybody's responsibility, starting from the guard in the facility to the higher officials. Each of healthcare providers, clinical and non-clinical, it's our responsibility. Strive to ensure healthcare quality in our facility and in our country. This is my message. Thank you so much.